Namaste Vidya, Hamisha खुश रहो बेटी. A very good morning to you all. Myself, JV'n Dr.Ravi Jain, Assistant Professor, Department of Practice of Medicine at JAYOTI Vidyapeeth, Women's University in Faculty of Medical Science. In today's lecture, we are going to discuss about infectious mononucleosis. Infectious mononucleosis. These are the symptoms, main symptoms of infectious mononucleosis. Infectious mononucleosis is also known as the kissing's disease. Mono may begin slowly with fatigue, malaise, headache, and sore throat, and the sore throat becomes progressively worse, often with enlarged tonsils covered with a whitish yellow covering. The main symptoms of infectious mononucleosis consist of central fatigue, malaise, loss of appetite, and headache. The visual symptoms consist of photophobia, the tonsils reddening, swelling, and white patches, and in the throat there is soreness and reddening. There is swelling in the lymph nodes, respiratory cough, and systemic symptoms of chills, fever, and abscess. There is splenic enlargement with abdominal pain and gastric nausea. Infectious mononucleosis is an acute viral illness that is characterized by pharyngitis, cervical lymphadenopathy, fever, and lymphocytosis. It is caused by Epstein-Barr virus, a DNA virus in the family Herpes viridae. It is a disease of the young adults and is more common in areas with a higher standard of hygiene. It spreads by contact with oral secretions and is shed in the oropharyngeal secretions by greater than 90% of asymptomatic seropositive individuals. The pathogenesis. It infects the epithelium of the oropharynx and the salivary glands, as well as the beta cells in the tonsillar crypts prior to the period of viremia. These cells undergo polyclonal activation, reactivate T cells, proliferate, and directed against Epstein-Barr virus, antigens during acute infections. The cellular immunity is more important than humoral immunity in controlling infection. The severity of the disease correlates with the levels of CD8 T cells and Epstein-Barr virus DNA in the blood. The clinical manifestations consist of 75% of the infections in adolescents presents as infectious mononucleosis. The incubation period is 4 to 6 weeks, and most infants and young children are asymptomatic. Some are present as mild pharyngitis with or without tonsillitis. Now we come to the prodromal symptoms of infectious mononucleosis. The prodromal symptoms consist of fatigue, malaise, and myalgia that are lasting for 1 to 2 weeks before the onset of fever. The fever is usually low grade and is most common in the first 2 weeks of illness. It may persist for greater than 1 month, whereas splenomegaly is more prominent in the second or third week. There is exudative pharyngitis and lymphadenopathy with tender, symmetric, and movable nodes. These are most predominant during the first 2 weeks. Lymphadenopathy is most commonly affects the posterior cervical nodes, but may be generalized. Pharyngitis, often the most prominent sign, can be accompanied by enlargement of the tonsils with an exudate resembling that of the streptococcal pharyngitis. A morbilliform or the papular rash, usually on the arms or trunks, develops in around 5% of the cases. The splenomegaly is more prominent in the second or the third week. The illness lasts for around 2 to 4 weeks, but 10% of the patients have fatigue that persists for greater than 6 months. The clinical manifestations depends on the patient's age and immune status. In elderly, presents with non-specific symptoms, prolonged fever, fatigue, myalgia, and malaise. Pharyngitis, lymphadenopathy, splenomegaly, and atypical lymphocytes are relatively rare in elderly patients. Immunocompromised patients can develop lymphoproliferative diseases. Lab findings: white blood cell count is elevated and peaks at 10,000 to 20,000 per microliter. Lymphocytosis with greater than 10% atypical lymphocytes. CD8 plus cells predominate among the atypical lymphocytes. Low-grade neutropenia and thrombocytopenia are common during the first month of illness. Liver function test is abnormal in greater than 90% of the cases. Serum levels of aminotransferases and alkaline phosphatases are mildly elevated. The serum concentration of bilirubin is elevated in around 40% of the cases. Now we come to the diagnosis. The serological testing is mainstay of the diagnostic assessment. Specific Epstein-Barr virus serology or the immunofluorescence can be used to confirm the diagnosis. PCR analysis can be useful. Acute infection is characterized by IgM antibodies against the viral capsid, antibodies to Epstein-Barr virus, early antigen, and the initial absence of antibodies to EBV nuclear antigen. The complications. Most of the cases of infectious mononucleosis are self-limited. Deaths are very rare and occurs due to central nervous system complications, splenic rupture, upper airway obstruction, or bacterial superinfection. Acute Epstein-Barr virus infection is associated with cranial nerve palsies, Guillain-Barré syndrome, acute transverse myelitis, and peripheral neuritis. Some have severe diseases with hemoglobinuria and jaundice. It has been associated with red cell aplasia, severe granulocytopenia, thrombocytopenia, pancytopenia, and hemophagocytic lymphohistiocytosis. The spleen ruptures in around less than 0.5% of the cases. The splenic rupture is more common among the males than in female patients and manifests as abdominal pain, referred shoulder pain, or hemodynamic compromise. Hypertrophy of lymphoid tissue in the tonsils or adenoids can result in upper airway obstruction, as can inflammation and edema of the epiglottis, pharynx, or uvula. About 10% of the patients develop streptococcal pharyngitis after the initial sore throat resolves. The other rare complications include hepatitis, myocarditis or pericarditis, pneumonia with pleural effusion, interstitial nephritis, and genital ulcerations and vasculitis. The complication consists of splenic rupture, upper airway obstruction because of hypertrophy of lymphoid tissue, bacterial superinfection, CNS complications like meningitis and encephalitis, autoimmune hemolytic anemia, thrombocytopenia, fulminant hepatitis, myocarditis or pericarditis, pneumonia with pleural effusion. Now we come to the management or the treatment part. It is treated with supportive measures including rest and analgesia. Excessive physical activity should be avoided in the first month of the illness due to reduce the possibility of splenic rupture. Administration of glucocorticoids to prevent airway obstruction or to treat the autoimmune hemolytic anemia and severe thrombocytopenia. Antiviral therapy, that is acyclovir, is generally not effective. Aspirin gargles relieve sore throat. So this is all about infectious mononucleosis, or also known as the glandular fever. It is caused by Epstein-Barr virus, characterized by the causes of fever, fatigue, sore throat, and swollen lymph node glands. The signs and symptoms consist of prolonged fever, exudative pharyngitis, painless generalized lymphadenopathy, and splenomegaly. The diagnosis in 50% of the lymphocytosis with greater than 10% atypical lymphocytes on the peripheral blood smear. Positive monospot test, that is Paul Bunnell test. Serum hydrophile antibody definitive positive at 2 to 6 weeks. The complication consists of splenic rupture, respiratory obstruction, encephalitis, and lymphomas. The treatment is usually supportive with tonsillar hypertrophy, produces airway obstruction. Need to place the nasopharyngeal tube and start high-dose steroids. Do not give amoxicillin as it develops iatrogenic rash in 80% of the cases. This was all about infectious mononucleosis. In the next lecture, we will be discussing about leprosy. This session is powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I will try to resolve it. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow.